Welcome to the second half of the Child Fatality Prevention System Overview training. In this section, we will be addressing the implementation of local teams and funding from the State Health Department.
So let's start talking a little bit about how the local teams are going to be structured and what your options are for forming them. We do have 5 existing local teams, and I apologize to Broomfield County for this map because you are not on it. I apologize, it's an older map and I think kind of crowded there for Broomfield, but Broomfield will also be deciding how to form their local team or whether they're going to regionalize with other counties. There are 5 teams that have been operating in the last couple of years. Mesa County has the only team that's currently facilitated by the local health agency. So they are a great pilot site for us to test out some of the tools and reports and strategies that we are going to be providing technical assistance to all of you because they've been doing this process and they're currently coordinating it in the way that the legislation requires. So they've been around for a long time. Jefferson County is a relatively newer team within the last few years. It is coordinated currently by the District Attorney's Office and does have membership from the Department of Public Health in Jefferson County. Denver County has had a team for a long time. It's probably our longest standing team, very effective team that's currently coordinated by the Children's Advocacy Center of Denver. Then we've got Morgan County, which is also a great team and has been coordinated through a collaboration between the Department of Human Services and the Coroner's Office. And then we have Larimer County team, which we actually just learned about, and they're facilitated also by a Children's Advocacy Center, I believe. And so these 5 counties, we're really looking to get them up to speed with the data system and some of the pieces that might be new for them, but then hopefully they will agree to help test or take a look at the materials that we're developing over the next 6 months so that you all have really great information when you're forming your teams, and that's informed by local communities that are currently doing this work and have a good understanding of how these teams operate on the local level versus the state level. So as you know, the legislation that just passed did include a fiscal note, and so I wanted to highlight what total funding is available for local teams across the state. So this is the aggregated numbers, not numbers for each specific county at this point. So there are two pieces of the fiscal note. A planning year, which is what we're currently in, that goes from now essentially. It started July 1st of 2013 through June 30th of 2014. And that legislation or that fiscal note indicated that we need to distribute to local teams a minimum of $152,000 between now and June 30th to help with the planning and forming of teams. Then moving forward, starting next fiscal year, that starts July 1st, 2014, and then moving forward, we are to administer to local teams a total of $314,000 for the purpose of actually reviewing cases and coordinating the process. CDPHE also received an appropriation to provide funding to staff the program at the state level, and so the 3 positions that we hired are part of that, as well as Julie Richenberger, who you met, her role as time-limited record abstractor. Her position will end next year when the new teams are up and running and reviewing cases, but in the meantime she's helping us not fall behind. So we do have some staff that are also funded through this legislation, but wherever possible we are going to be providing as much money to local teams as we possibly can, both to support the review process as well as to hopefully implement some prevention strategies, which is the point of this whole system. So in the fiscal note, there's also some additional funds to host trainings for local teams, in addition to the amount that we would be disseminating for the review process. So we are likely to hold annual meetings of some sort, probably at first for the coordinators to give them a chance to get to know each other and to provide technical assistance. We also hope to invite the National Center for Child Death Review to come and meet with us and do some of the training training that they can provide to help get us all up to speed. And then there's also a little funding included in there for prevention. And so what we're thinking right now is that we may be able to provide some mini grant funding in addition to the money that's going for the review process to help local teams actually implement prevention recommendations. We're actually going to pilot test this process with some of the 5 existing teams, should they agree to start to implement some of the recommendations that come from them. We'll be providing them some additional funding to actually implement those recommendations, and then we'll be incorporating, seeing how that works, and that'll serve as the model for what we do moving forward. So for the planning money, the planning stage, this is the breakdown of how money will be distributed between January and June of 2014. So each county will receive a total of $2,500 to determine kind of how best to structure their team. We need to know whether your local health agency's jurisdiction, whatever that is defined as. Some of you I know are single county local health agencies. Other of you, like Tri-County Health Department, for example, I know houses 3 counties, and we'll have to decide how to run this process there. Others of you might be single counties but wanting to form a partnership to review these cases, and all of those things are possible. But what we need, what this planning money is for, is to help support your costs in convening partners, for travel, for trying to figure out how you're going to structure things. The money is additive, so for, just to use Tri-County as an example, since there are 3 counties within the Tri-County Health Department's jurisdiction, they will receive $7,500, $2,500 for each county. The reason for this is, even though it's a single local health agency that's working with those counties, the partners at the local level that need to be involved are throughout each individual county. So there will be an amount of kind of coordinating things at the local level. And then, as I mentioned, the 5 existing teams will receive this $2,500 for their planning and kind of adjustment to whatever they need to do. They'll probably also be actually getting trained in the data collection system if they're not already, and some of the processes. And then we're hoping that they will agree to pilot test for us the new processes so that we can get some great feedback from them before we roll this out in a larger sense to all counties across, or all teams across the state. Then after June 30th, 2014, we are moving to our more regular funding cycle. And so in order to do that, we developed funding tiers and, based on the number of cases that local counties have had over the last 5 years. And so these funding amounts are preliminary. We're actually in the process of verifying them and taking a look at it, but this was our first cut at trying to disseminate the money in an equitable way that is in line with what the fiscal note said that we need to provide to you. And so this is a little map of where the county breakdowns are and how much people will be getting for different cases. So let me just walk you through briefly how this funding formula was created. First, what we did was we took a look at the number of child deaths that meet the criteria for review in the mandatory category, so those preventable child deaths, roughly 200 or so a year, and we spread them out from each year from 2008 through 2012 and looked at that five years and kind of then grouped made a total to group what we were seeing. And what we saw is a majority of counties were following in that kind of under 4 area, and then some of the larger counties started to get into the 5, 15, 30 and on up for their number of cases that they had seen in that 5-year period. So what we decided to do is take a look at the sort of worst year in that 5-year period that a county experienced and base the funding amount on the worst year, rather than basing it on the average. So for most counties, what it worked out to be is that you are actually going to get funded at a level that is almost double of what we were thinking we would be able to provide based on the formula that was in the fiscal note. So what we have is looking at the highest number of cases that happened in that 5-year period. And then we looked where that fell in this funding tier system that you see there to the left. And then we decided that rather than base the amount of money on the actual number, we would base it at whatever the top of the tier was for the funding. So this created sort of a worst case scenario standpoint where we wanted to make sure that teams have the resources that they need to review cases, knowing that the actual number of child deaths that will be reviewed will fluctuate a little bit from year to year. So just to use an example, so if a county had in between 2008 and 2004, some years where they had 1 death, some years where they had 3 deaths, some years where they had 5 deaths, what we would do is say, okay, we're going to base the funding formula on 5. And then that's the number of, the deaths. And then we look at the funding tier, which is in the 5 to 10 category, and the money is going to be based on the number of cases at that top of that tier. The funding amount was figured in 2 ways. One is a base level of funding of $1,000. So every county, regardless of if there's deaths or not, would receive funding for $1,000. And then for each case that was at the top of that whatever tier they were in, they would receive $700. So for counties, there were 6 counties that had no deaths at all in that 5-year period, just because a child death can occur at any time, and we want to make sure that we're planning appropriately. We are going to be providing counties that had no child deaths in that 5-year period the $1,700 versus $1,000 because they may, worst case scenario, have 1 death coming up, and that would have to review. So these are the funding amounts. We're happy. I know it's a little confusing on a webinar to go through the funding formula and all of that, but we're happy to discuss the funding amounts. And again, we're going through, based on this map that we have here, going through to verify the number of cases are correct for each county. So, these may fluctuate just a little bit in our regional meetings. Some people pointed out some things to us that might indicate that we need to make some adjustments to the formula or go back and look by hand kind of what the computer assigned and make sure it's right. So we'll be going through and doing that, and then of course getting back to you about your individual funding amount so that you can plan. One of the things we are really trying to do is make it consistent so that you knew exactly what you were getting and were able to do that. So how will the funding work? And I apologize to those of you who might not be from a local health agency. This slide is geared a little bit towards them because the onus for forming teams is the responsibility of the local health agency. So in an ideal situation, we are going to try to incorporate the funding for child fatality prevention system into the local contracts with CDPHE's Office of Planning and Partnerships. In talking with some of you, some local health agency stakeholders, this seems like the most efficient way to get the money to you in a way that can really be useful and to not have a big administrative burden on you or on us for such a small amount of funding in most cases. So we would ideally like for this to happen through OPP. For the planning year, this can't occur because OPP's contracts, of course, are already out the door. So we are working through the Prevention Services Division, which is where the Child Fatality Prevention System program is housed within CDPHE, and we'll be issuing scopes of work. It's actually a purchase order, not an actual contract. Purchase order for counties that are receiving more than $5,000 will have to have an actual purchase order. And then for those of you that are just receiving the $2,500 for each county, we will be allocating that money to you via a straight pay situation. And so we'll be working with you, and we have a scope of work for that as well, so that you are clear about how that money is going to be used. But moving forward, for the money that'll start July 1st, 2014, so fiscal year 15, the funding will be incorporated into LPHA contracts if we know how the local teams are forming and who the coordinating agency is going to be by February. So the Office of Planning and Partnerships has given us a deadline to give them what funding amounts need to be added to existing contracts for the next fiscal year for local health agencies by February. So if you are interested in this option, we'll be working with you individually to explain this in more detail one-on-one, but please know that we do sort of need to have a game plan, at least to know who's going to be the coordinating agency and whether your local health agency is going to partner to form kind of a regional team or if you're going to be a single county team by February. So the other thing that the legislation allows is if a LPHA, local public health agency, designates another coordinating agency, so the local health agency is doing the work to make sure that there is a team going on in their area, but they're not going to lead it, that is still possible. But in that case, the contract will need to go through the Prevention Services Division of CDPHE and not through the Office of Planning and Partnerships, since the Office of Planning and Partnerships only works with local health agency contracts. So again, we'll work on an individual basis, but please know that this is an opportunity for you moving forward. Please let us know as you have funding questions, and again, I think probably there's lots of individual situations across the state that need to be discussed, and we're happy to provide that one-on-one technical assistance with you and explain this in more detail in that format. So some different team models to explore. So we've kind of alluded to some of these, but just in a snapshot sense, there are two ways, two models or so that you can kind of think of your team. So if you are a single county local health agency, so that your jurisdiction covers one county and that's what you do, you can choose to be a single county review team. Or you can, if you are Tri-County Health Department or the Northeast Health Department, a multi-county health agency as it is, you would obviously have the ability to be a multi-county review team. Or if you actually are a local health agency that has just one county in your jurisdiction, but you want to partner with other counties, you can do that and form a multi-county team. So let me just walk you through briefly some things to consider for each of these models. So a single county review team, might be how it works. So the local health agency or another agency that's designated by the local health agency will facilitate the review process for its jurisdiction. So this means the deaths that we'll identify to you are just from the county that your agency serves. The team members for this local single county review team will be members from agencies within that specific county. And agencies can then, of course, choose to bring their information for the review, or as I mentioned, they can send information or records that they have to a coordinator in advance of the review. We can work out some of these details with you and strategize based on how your team is set up, what might be some good options for you, but there's some different options for the record collection piece. And then you're only going to meet as often as necessary to review the cases. So for large counties like Denver County, I believe, meets every other month. The Morgan County team meets quarterly. The Mesa County team meets quarterly. So you're going to meet as often as you need to get through all your cases. So the bigger you are, the more often you'll probably have to meet. The smaller you are, the fewer cases you have, the less often you'll have to meet. And so there is a possibility that if you are one of the 6 counties that had no deaths in the last 5 years, that you may not have to meet in a particular year. However, we still will require people to be, connected to us, and we'll still be providing you reports and things like that. So there's still a small amount of work that will need to be done, even if you aren't reviewing cases, but it'll be pretty minimal, and that's how we'll be moving forward. The county team or a single county team can meet with other single county teams within a region to discuss prevention recommendations. So if you're a single county team, you're doing the reviews on that level, but you want to talk about prevention in a regional sense, that's also a possibility. And again, that structure, we can work out the details and give you some more individual advice about how that might work. So two options for multi-county, or what we've been referring to as regional teams. One is that a multi-county team would have all county agencies represented in some way. So let's say a six county, we want a six county team. So under this model, you would have a very large roster of all the agencies that are in at least that mandatory category within that review team. And then you would end up with multiple agencies from the same discipline but from different counties. So for example, you might involve, if you have six counties, you would have perhaps 6 county human service departments on your agency list. What you could do then is just convene that team when you needed to, or call on certain members on that large roster list to review specific cases depending on what who has information for what kind of situation. So in this case, you might have one coordinating agency that's facilitating all this and kind of coordinating the process, but really your team is this large list of people that can be on call for when there's a review in their area. The other option could be that you have a multi-county team, but you have discipline representatives. So rather than having multiple representation from county human services or law enforcement, for example, you might have a county human service department within that 6-county region coming to the meetings and being part of the team, and just facilitate the reviews that way. The downside of this, of course, is that the idea of local teams really revolves around making sure that the people who investigated the deaths or know about the families and have information to provide are at the table. And so if you just have a representative from that discipline, it gets a little bit closer to the state level process that we've been doing in Colorado for years, that just isn't really ready to make specific prevention recommendations for that area, because the representative you may have on your team may not be someone that is familiar with the county where the death occurred, if that makes sense. But there are, some different possibilities here in how you structure. So for these multi-county or regional review teams, the LPHA jurisdiction would cover multiple counties, so like in the case of Tri-County or Northeast, or the partner collaboration between local public health agencies is forming that multi-county. The coordinating local health agency or its designee would facilitate the review process for all counties on the review team. And it again would meet as often as necessary to review the cases. So depending on where the regions form and how many cases you could review, it's possible that you would only have to meet once a year, or even less than that if you needed to. This model will, unless you're already a health agency like Tri-County Health Department or Northeast, that by virtue of your health agency structure you cover multiple counties. If you're forming your own region or using an existing partnership for the review process, you will need to have an MOU so that we know all of the health agencies in your area agree to the model that you're going to be putting into place. So this will require an MOU. And then, of course, you can invite specific team members, just like in the last model, as necessary to review the case, and people can just, either bring their information in with them or send it to you in advance. So some pros and cons of regionalizing. Pros are, of course, the money is additive. So if you are a 6-county region, for example, the money that you would be getting for each individual county per the funding formula could be aggregated and then put into place for the coordinating county's OPP contract, for example. So that money, when it adds together, may be a big enough chunk of money that you can support staff for the coordinating agency to facilitate the process, and give you a little bit more resources as a collective to do the reviews. The other pro is that you'd be reviewing cases more often. So in particularly small counties where you just have 1 or 2 or no deaths in a particular year, it's hard to really get the hang of this if you're just meeting once a year or hardly ever do it. So if you regionalize, the idea is that you would probably have more cases then for your team to review, and you'd be doing the process more often, and you would be able to be able to see how it rolls on a more regular basis and feel more competent in your area. You also have the opportunity from learning from other communities. So rather than just being a one single county team, the regional approach allows you to benefit from ideas that are happening in all of the counties that are represented in your region, and the different agencies that might be on the team, etc. So there is value in sort of learning from your partners and seeing what's happening and what good ideas are coming about in other areas. The cons for the regional approach would include it could be more difficult to collect case records. So the bigger your jurisdiction for your team gets, the more difficult, the more agencies you're going to have that you're going to have to be up on, who has information, how to receive it, how to contact those people. So for a particular coordinating agency that's dealing with counties outside of the area that they normally work in, it can be administratively difficult to get all of that information for the case records, or even just to know who to contact to attend the meetings, because the turnover happens and people come in and out of their positions or move away, new partners come in, and it's hard to keep track of that all. I can tell you at the state level, since we are currently facilitating the reviews for all counties, it becomes really difficult to kind of aggregate everything in a big way, because we always have to track 264 law enforcement agencies and 64 coroners and all these hospitals, et cetera, et cetera. So you may have a more challenging time, not guaranteed, but you may have a more challenging time getting records if you're taking the regional approach. So the pro of regionalizing is that you're going to meet more often. The con, of course, is that you're going to meet more often. So for some counties that may be thinking about regionalizing, you do need to think about the geography and the idea that to be most effective, you need the people at the table who actually know about the case. And that could mean that travel is an issue for full participation in the meetings. I think there's ways around it, and you can certainly, you would know better than we do about how logistics work in your area and what's possible, how far people are willing to travel for a meeting, but you may have to explore meeting online software or other types of strategies to make sure that that people that need to be at the review are able to attend. And so again, more meetings and logistics can be more challenging. So real briefly, I want to walk through the timeline of how all of this is going to work together. Some of you may have seen this. This is on our cochildfatalityprevention.com collaboration website. This is our timeline that we've been using internally at CDPHE to kind of sketch out how the implementation is going to get up and running by January 1st, 2015. So you can see on this timeline here the regional meetings that we held in October, November, December. This is our kind of last piece for those regional meetings. We're in the process of receiving or issuing planning money and trying to figure out the process to do that by January, so that we can get you all monies to start planning. But then this key deadline here, the March 31st, 2014, is a date that will be becoming very familiar with all of us in terms of how to stay on track with the system as a whole. So I want to try to explain just briefly how this timing works for when cases are reviewed, and then I'll go into more detail the full process from start to finish. But right now, the state team is reviewing cases from 2012, and we are hoping to finish the review of all those cases by March 31st, 2014. The reason that date is there as kind of a deadline is because our legislative report is due July 1st, 2014 to the legislature. So in order for us to have enough time to analyze the data and get everything up and moving, we need to finish the review of cases, get the data all in the system and finalized, run the reports, run a process with our state team in order to make the recommendations that go into the legislative report and get it out the door by July 1st. So then next year, what we're looking at after this legislative report is in, or really after these cases are done, we're going to start reviewing 2013 cases. Those cases don't need to be in the system until March 31st, 2015. So you can see in terms of from when a death occurs to when we need them finalized and full through all the process can be anywhere from a year to a year and a half. The reason for this lag in time is that we really want to make sure that this process is not part of the investigative process. We are, for child fatality review, just part of looking at the trends and patterns retrospectively and identifying prevention strategies, etc. And so in order to be able to do that effectively, we have to have complete case files with finalized information. So some deaths, like motor vehicle deaths or some sleep-related deaths, may close out very fast, and you would be able to review those pretty soon after the death, 2 or 3 months after the death, for example, or even sooner than that if the investigation's over. For child abuse and neglect cases or homicide cases in general, the legal process can go on for quite some time, and so we don't want teams reviewing cases until those investigations are finished, so that it's clear that we're not part of that investigation process. We're really, looking at the complete investigative information in order to input that into our system, and then that is what's used to aggregate and make broad-based prevention recommendations. So there's going to be quite a bit of a long time between when the cases are identified to you, which is going to be happening on a rolling monthly basis, and when they actually have to be in the system and finalized, and then we'll be reporting on that data. So I know this gets a little complicated. I think the next slide will help you out, help you kind of understand how it walks through the whole process. So let's look at the process that we're going to use to identify cases to you. As I mentioned, we need to do this in order to make sure that all child deaths that occur within a particular year receive a full review. So we are going to be reviewing cases for local teams on a monthly basis. This will be done using coroner jurisdiction. So last legislative session, there were some changes to the coroner statutes as well that made some adjustments to how their jurisdictions were defined. And so after talking with some coroners and medical examiners, we determined that the most efficient thing to do for us would be to use coroner jurisdiction to identify jurisdictions for local teams. So coroner jurisdictions are county-based, and since the coroner system is a county-based system, and they are defined about where the incident leading to the death occurred. So this means that if a motor vehicle crash happened in one county, but the person was transported to a hospital and died in a different county, the coroner in the county where the crash occurred would have that case. In some cases, these things align, of course. So if you had a resident of Adams County die in Adams County for suicide, for example, or a different reason, then that case obviously goes to the Adams County coroner, for example. So we are going to use the same system to identify cases, and the funding allocation and everything that we described to you earlier in the presentation here was based on these coroner jurisdictions. Since they're county-based and so are roughly local health agencies, even though some have multiple counties, we will be able to adjust and assign cases that way, I think in the most easiest way possible. So we'll be doing that on a monthly basis. Each local child fatality review team or regional team will have a folder on a secure file transfer protocol site, or usually just called FTP site for short. And what this is just a way that we can transfer death certificate information to you in in the most efficient way possible, so that you can have identifiers and everything and not be worried that that information gets out in an unsecure way. So we are going to be giving you a modified death certificate form with information that includes the basic information that you need from the death certificate to fill out on the case reporting form, as well as some spaces that you might use for tracking purposes. So this form that you can see on the screen right now is a sample of the modified death certificate form that we use currently in the state level review process to kind of track and manage the death certificate information. We will be working with the 5 existing teams in the next 6 months to show them different models and versions of the modified death certificate to make sure that it makes sense for them and that it's the most efficient way that we can possibly get that information to you. But this is our idea for now. The death certificate information comes to us actually in an access database, and rather than make sure that all local teams have someone that understands access database, we'll be giving you some sort of one-pager that just includes the information that is the most important for the case review process. CDPHE and each local team will reconcile the number of cases assigned and reviewed on an annual basis. So thinking back to the last slide with that March 31st deadline, when we get to, perhaps December, January, before that March deadline for a given year, we'll be looking into the case reporting system to see what cases you actually reviewed and are in our data collection system versus which ones we assign to you and are in that FTP site. And if there's any discrepancy in there, we'll be contacting you and just deciding how to move forward. Either the state team can review cases that you missed, or perhaps the situation happened where another team reviewed that case, or you felt like you weren't appropriate to review it for some reason. So we will reconcile that on an annual basis to make sure that we get all of the data in the system for that data year by March 31st, 2015. So I think it is a ton of information to impart in a pretty short webinar or short training. So I'd like to just walk you through the whole cycle as a whole, and hopefully this will make it a little bit more clear. So let's say a death occurs in a particular county, and then of course the investigators go out right away and investigate that death. Most of these cases are coroner cases and will have investigations that are associated and reports that are associated with it. There will be a few cases, perhaps the natural SIDS cases, for example, that may not be coroner cases for whatever reason. And if that happens, what we'll do is still assign the cases based on that coroner jurisdiction, even if there's no autopsy or records to collect. But generally, from when the death occurs to when the investigation occurs, this happens very quickly. Then coroners continue to investigate and eventually rule the manner and cause of death. Coroners have a month or two to notify the state that that death has occurred and get the death certificate into the system. And so that certificate gets sent to CDPHE. So we're looking at a 1 to 2 month lag time perhaps from when the death occurs to when the state health department has that death certificate. And then once we have that death certificate, we're going to be making assignments to the local child fatality review team. So the lag time here will fall, anywhere from 1 to 3 months to get to this point in the process. So after CDPHE has the death certificate in our system on, say, the 15th of every month or whatever day it ends up being, we'll be getting a file from the Office of Vital Statistics showing us here's all of the cases that occurred since the last time that we updated the system, and then those cases will be automatically assigned using an algorithm to the appropriate team based on coroner jurisdiction. Then after that file is in your team folder, what you'll be doing is requesting records on that child death, or you'll be asking members of your team to bring records with them or somehow get you the information that you need in preparation for the review team. So the lag time between when you get sent the local child fatality review team assignment for this case to when you're actually going to request records might depend on your timing. Because there's up to a year and a half lag time between when a death occurs and when that data has to be finalized in the system, in most cases you'll know between 12 and 18 months that you have a case to review, which will give you plenty of time to think through what you want to do for requesting records, when you want to have your meeting, if you want to invite any of the CDPHE staff to come help you with the review, so you'll have lots of planning time there. But you can do it soon. So for some local teams, for example, the Denver local team currently reviews deaths pretty quickly after they occur because the coroner just identifies those cases directly. They don't wait for the state to get a death certificate and to get them, in the system. And that's fine for you too. If you find out about a death in another way, particularly in small towns, you're going to know probably right away that these things have occurred. Unless the death is still pending investigation, you can go ahead and review that case even if we haven't identified it yet to you in the system. So please keep that in mind. The timing here is fairly loose, and you'll have there's not going to be any surprises in terms of, oh wait, there's this case that you have to do really quick, pull your team together. You will have at least a year to pull things together and get your team up and going. But if you want to do a much faster timeline than that, that's fine. And again, what we'll do is just reconcile those at the end. So let's say the team has requested the records and we're moving forward, so then you need to call a meeting for the multidisciplinary review. And again, it can happen in a variety of different ways in terms of who you invite, but the idea is that the people at the table for the case reviews know something about the case and the community and can have a good, meaningful discussion about the circumstances and a nice sort of brainstorming session around the prevention strategies. So when you meet to review a case, you will review the information and then you'll enter cases into the data collection system. At the state level, we actually start entering the cases into the system before we even have the review meeting. So it sort of just depends on what works best for you. We bring a computer to the review meeting and finalize all the data in the system in real time while we're sitting there so that we don't have much follow-up to do after the meeting is over. But you'll get comfortable with however you really need to make sure that process happens. But at some point, and per the legislation, between meeting for the case and getting the cases finalized in the system, you're looking at no more than 2 months for that process there. Then you will also have the ability to just implement systems improvements that are, identified through your case review. So sometimes, what happens when you're sitting around talking about a particular case is it identifies some issue of communication or some issue of other, types of problems that you can fix within your community right away without having to wait for aggregate data or looking at things. So, an example of that might be just improving the communication between the hospital and the coroner's office, for example, or something along those lines where you can just make the change right away and move forward. So there's no need to wait for the state to give you data to decide to act on something that your community thinks needs to change. We're not going to connect it back to a particular case and publish a report about it like the Human Services Review would, but we do want you to act and capture those strategies that you implement at the systems and the community level so that we know what good work you're doing there. So you can go ahead and do that. After you've entered the cases, the data is going to be available in the data collection system for us to view at the state level. So at the state level, we're the administrators of the data collection system. Anything you put in there, we can see at the state level, and so we'll do some training around this for the coordinator, whoever is going to be entering the data. When you check a box saying that your data entry is complete, that's going to be our cue to look look at the case and make sure everything looks good. And if we have any questions, we can contact you. If everything looks fine, then we'll just get that ready to incorporate into the aggregated data. And then we're going to be doing the data analysis. So the data analysis is really, there's some quality improvement or monitoring that's going to happen throughout the year, but the majority of the data analysis is going to happen in April each year, April, May timeframe. And so getting that information in the system by March will trigger what our data analyst does in April, May in preparation for that July legislative report. Once the analysis is done, we're going to kind of have two pieces. So we'll have the aggregate data report about the fields and information circumstance data that you've entered into the system, and then we'll also aggregate the recommendations that all of the teams across the state have compiled. So again, we're never going to take those recommendations and connect them to individual cases. So when you're thinking about reviewing child deaths and talking about the systems and recommendations that might be put into place to protect children, you can think of it in sort of a brainstormy kind of way, because putting your recommendations into the data system will mean that we can see that. We're going to pool those all together, look for trends and patterns, etc., in that kind of more qualitative data, and then we're going to use both of those pieces of information to write reports for all the local teams as well as to the legislature. So we're using the same information, and again, this all comes from you all at the local level. That information is what gets fed into these reports that go back to you, as well as what goes to the legislature. And then, most importantly, we're implementing prevention strategies. So some of you may be wondering at this point, kind of to take through that whole process, some cases will vary a little bit in the timing. Some cases you might review 1 or 2 months right after the death occurs. Other cases, like child abuse and neglect cases, you may have to wait a couple of years. And there is a possibility that there could be a child abuse and neglect case that we want to close out in the system just for our data year. That's really, you haven't done a full review on yet, and that is okay. There's a box in the data collection form to check that that's the circumstance, so that we know that case has incomplete data. It might just have the death certificate information, for example, or just basic information that's not part of the legal holdup. And we'll then, whenever that information is available for that case, you'll enter that back into the system, and then we'll catch it for the churn data in the next year. So the timing will vary a little bit, and the funds that you will be receiving to run these local review teams can go for a couple of things. So certainly, the data collection process, meeting to review cases, all of these things might cost some money to be able to review. So things that you can spend your money on would include, travel to support team members traveling into the meetings, or technological support to make sure that people have the technology they need to be able to participate in meetings remotely, mail or fax costs associated with collecting the records, staff time for somebody to actually facilitate that process and fill out the data collection tool. And then some of you, may still, after all of that, have some money, or perhaps you're a county that won't have a death, only you have to meet once a year, so you're not accruing very many costs there. Where you can focus your energy and spend that money is here in the implementation of prevention strategies. So we will specify, what the money needs to be used for, but there's, some opportunities to use it in a broad sense for anything that is going to contribute to preventing injury, violence, and suicide for children in our communities. And so we'll be giving more detail on a later webinar about some different ideas for how you can use the money that you'll be receiving for this process for prevention, and then most importantly, how we can take that money for prevention or those ideas for prevention and leverage other funding sources to have kind of more funds available to actually impact these types of deaths in your community. So effective child fatality review teams, again, will improve our understanding of why children die, and will inspire taking action to prevent future occurrences. So I want to just keep saying, bringing this back, it really is all about the prevention. I know that was a lot of process stuff, and there's a lot of details that perhaps sound a little complicated via a webinar, but I think when you get into the process, you'll realize it's fairly intuitive in terms of how these systems work. But the whole point of it all is prevention. So using your funding for supporting prevention initiatives that are already going on in your community or initiating new ones are certainly things that we want to help you accomplish, and we're going to be available to help you design those strategies and to try to implement them. In order to help you, you really operate your teams, and I know that the amount of information can be overwhelming at times. We did prepare a Child Fatality Prevention System Operations Manual, which is available at www.cochildfatalityprevention.com. This manual outlines all of the various steps in the process that I just went through in that timeline slide, and includes much more comprehensive information about the role of each member on a team and how the funding works and how the timeline works for preventing cases, how the FTP website works, etc. This manual is going to be in draft form until January 1st, 2015, and the reason for that is that we really want to ask your feedback for it. So the website that we have all the information on is a blog site, and you are welcome to provide us feedback or to collaborate with your partners across the state to let us know what's missing from the manual, what you need to be effective in your job. But you'll see in here anything from job descriptions for local coordinators to different timelines, description of manners and causes of death, and a whole glossary of terms, acronyms, and things like that. So we're hoping that this will be really a good, useful tool for you, and welcome you to provide us feedback. The 5 local existing teams will be in the next 6 months providing detailed feedback for us so that we can make this better and better even for 2014. So real quickly, I'd like to go through a demo of the child death review data collection tool. This training is not going to be comprehensive, and this is only a snapshot of what the system does. Again, once we have coordinators identified in the different local teams, we'll be meeting with people individually as well as in groups to figure out how to orient you to the system and get you signed up. So this is the landing page for the Child Death Review Case Reporting System. You can see that here everyone will receive their own username. This is something that we assign here at the state level, and we'll be administering this site. And then you have a password here that you'll set that'll be unique to you to get into the system. The data on this system is very secure. It's housed in a database in Michigan through the National Center for the Review and Prevention of Child Deaths. They house the data system, but we have a data user agreement for the state of Colorado and this site that indicates that none of the data that we input into the system can be shared without our knowledge and written permission, and this has passed the muster for our Vital Statistics Office in terms of being a secure way to record this data. In addition to that, we are not going to be putting identifiers into this data collection tool, so we'll again explain a little bit more about that as we move forward, but since we don't need to collect names and things like that in the system because we're not analyzing the data in that way. So when you click on and you log in, this is the main page that you'll see, and you can see that we're logged in as me here. Your screen on this side will look slightly different depending on what access you have. So I'm the administrator for our state, and so you'll see that I have an administrative account and can manage passwords and those types of things here. Each county will have its own kind of section here. So this data case definition is the case number that gets automatically assigned for the system. So all of us in Colorado by alphabet are state number 6. Each county will have a drop down for each county name. We're going to do it by county and then give access to the coordinator of a multi-county team all of the counties that are within its jurisdiction. Designing the system this way makes it a little easier to adjust if counties decide to regionalize later, or they regionalize now and decide they want to add people or break up the region. We can manage the site and make sure that we have good tracking of all the information. So this is just the El Paso County team. If, for example, El Paso County and Fremont County decided to combine to a regional team, you would see that team coordinator would see El Paso and Fremont as choices in this drop-down box. Then you'll have the year that we're actually reviewing the case. So for us right now, it's 2013 for a couple more days here, and we'll be entering the case year here, and then the system automatically assigns a number to you based on the number of cases that you've input into the system for a given year. All of the cases that we enter are going to be child deaths, and then we are going to be using the death certificate number as the unique identifier for these cases. As I mentioned, we are not going to be entering names into the system, and so this is an important piece here that we make sure that we have this death certificate number in there so that we can tie it back to vital statistics data if we need to. To manage your cases, you can see here how we don't put any first or last names in here. We've got a case number, we've got a date of death, manner of death, and what local team is entering the data. You can see that there'll be a column when you say that you're done with the data entry. We'll be able to track that here and be able to know when we need to go in here and do quality assurance. So that's something that we'll do. You can also print out case reporting tools here. You can manage your cases at any time, so you can get in and out of the cases. They don't have to be, you don't have to do all the data entry at one time. You just use this case number again, and you can log into the same case and continue to enter information. So after we enter the basic demographic information into the system, you'll see here if you have a paper copy of this tool, and we are happy to provide paper copies to you. They're free to us from the National Center, and we have several hundred here that we can disseminate to you. You can also download blank copies of this form directly from this website through the help function. So we'll again walk through all those details when we have someone for your team to kind of manage this data piece. We will be happy to give them more detail. As you can see here in red, this tool tracks exactly with the paper tool. So there's different sections in that paper tool. The first is the case definition, which is that page I just showed you where you put the death certificate number. Then you'll have information about the child. You'll have information about the primary caregivers, which are usually the parents of the child. You'll have information or a section about the supervisor if the primary caregivers of the child were not with the child at the time of death. So this might be a babysitter, for example. Then you'll have information about the incident itself, sort of what happened, the investigation, so knowing who was on scene, what time of day it was, a bunch of investigative questions. And then this section, which is shown on the screen here, which is section F, manner and cause of death. So this is where a lot of the skip patterns are put into the system. So by checking accident, then a particular cause, so say drowning, then this tool will take you to section G that you'll see is left out here, but that's because there is a section G for each type of child death that you can think of. So there's a specific drowning section, a specific motor vehicle section, a specific suffocation section, etc. So this is where a lot of the skip patterns go in. If you're using the paper form to kind of take notes and lead you through the process, the skip patterns are instructions are written on the paper form, but I will tell you that just entering cases directly into the web-based tool is a lot easier in terms of knowing that you're getting the skip patterns right and not entering information that's unnecessary for the case. The system also includes the ability to create standardized reports. So any data that you guys put into the system from your local teams is available to you through these reports at any time. So there's a variety of different topics. on, motor vehicle reports and suicide reports and child abuse and neglect reports, or just straight demographic reports that are looking at, ages and race, ethnicity, those types of things. So you can get in here, put in the name of your team, and select the year of death you'd like it to be reported on, and you can just automatically, at the push of a button, generate a standardized report. We are also available at the state level to do customized reports for you at any time that you may need one, or if you just have a quick data question for a report that you're writing for your agency, or maybe a question that you got from the media, we can run that specialized data request. But if what you need is just a quick snapshot of what are all the cases that we looked at, and you want to share this information with your team members, this is a quick, easy way to do that. This is just one of the pages in the motor vehicle standardized reports. So you can see you've got some basic information about age of these motor vehicle crashes. You can see here that we have, most of the motor vehicle fatalities in our system right now are teens. And even though I mentioned we've had great reduction in teen motor vehicle fatalities, there's still a lot. Tells you passenger, driver, bicycle, pedestrian, etc. Lots of different information, and then there's actually several more pages to this report that talk about seatbelts and talk about other things. So the reports are pretty good, and do give you some basic information, and it's nice that you can just run them yourself without having any kind of data expertise whatsoever. So let's talk about confidentiality a little bit, and we're going to show you, there's some resources on here, sample confidentiality forms, etc., in the operations manual as well as on the website. But one thing that we do immediately when we convene a review meeting is to have everyone sign a confidentiality form. If you're a team that meets on a very regular basis and have consistent membership, I would suggest doing this once a year, and then as long as you have it on file, the only confidentiality agreements that you need to get can happen just if there's new people, and then you can do it again the next year. That's what we do at the state level. But for those teams that are going to meet just once a year or really infrequently, it might be good just to do these all at once. So what you can see on your screen here is a copy of our confidentiality form that we use at the state level. This is something that you can use and change to reflect the language that you need it to say, or you can make up your own per your agency's agreements and requirements. But we definitely need to have it. The conversations that happen in these review meetings are confidential and need to be kept that way. And so, this is just a protection. We've not had any instances where a member of our state team has broken confidentiality, and we haven't had to take actions against any of our members. But if there was a situation where information was inappropriately shared outside the meeting setting, this is something to protect you and to verify that all the team members know that there is confidentiality in place. The other thing that you'll see in the legislation that is a protection for confidentiality is that information about the Open Meetings Act. So in the operations manual and then on the website, we have a copy of the section of the statute, and you can see it on the screen here just for a quick glance, information about what this means. So since this process is run by both state and local governmental agencies, all of our meetings are open to the public. However, there are some instances where it's not appropriate, obviously, to have the general public in your meetings, and that is the section that talks about executive session. So here you see the section on executive session, and what this means is that if you are going to be discussing confidential information, which all of the information that comes across for child fatality really is confidential, that you need to actually formally go into executive session before you begin your case reviews. So this document here is what a script that we actually use at the state level to read through and to notify our members that we are moving to an executive session. It's a little bit long, and so you'll see that we cite the statute and the purpose and all of those things, but this is again just to protect us and to know that if you do have someone who wants to come to your meeting but isn't appropriate to be there, not part of your team, and not someone that it's appropriate to be in the review, that you do have the use of the executive session to make sure that occurs. You'll also see on this template of the script that we use, it says start recording in the corner. We are required to record sessions, and the purpose of this, again, is just to protect you. So it seems a little overboard, and it maybe is a little um, anti-intuitive to think about how you are having a confidential conversation, which is why you need to be in an executive session, but yet you're recording it. The reason for this is if anyone were to ever question whether you are in executive session for an appropriate, legitimate reason, a judge could listen to the recording and determine whether that is an appropriate use of executive session. There's really no question in the case of child fatality review, and we've never had anyone challenge this at all. So, in 20 plus years doing this, there's not been an instance where we've run into a problem. But we still do record the meetings, and we keep them on file per our agency's retention policy, which is 2 months, and then we delete them and have a record of when they were deleted. It is up to your agency and the retention policy that either your agency or team sets how long you keep those recordings. So it can be very short if you want 2 days, for example, or something. And again, this is just to protect you and to make sure that that if anyone were to call into question what you're doing in these meetings, you would have evidence for a judge that you were discussing things appropriately. The executive meeting session and the recording of such is really meant more for things like boards of health or some kind of decision-making body who, let's say, was having a public meeting and discussing a certain course of action, and then they called executive session, and they came back from that executive session, called a vote, and voted in a way that made people wonder what really happened behind closed doors. In that instance, the judge, could listen to the tape and say, no, that wasn't an appropriate use of the executive session, and that decision that the board made needs to be reversed. We don't really vote on things in that way here, so it's a little bit different, but again, the statute mentions Open Meetings Act, and so we follow it, and you are required to follow it as well. So let's just talk briefly about the meeting process, and this is very brief because at the regional trainings we actually did mock case reviews and showed this in person. On the webinar we don't have that benefit, but we may hold some additional meetings for people to be able to kind of learn what this is about, some mock case reviews, or if people are interested in participating in a state review and you are part of a local team, we will allow you to sit in or call in for one of the state review team meetings so you can kind of see what this is about. But at every meeting, this is basically the process. We review the information from the cases, which includes sharing information from different agencies, trying to get a sense of what happened, allowing members of the review team to ask questions and to clarify things, discuss the investigation, the services, agency practices, prevention, and then a bulk of the meeting is actually spent talking about prevention and talking about what the recommendations might be. And again, we will provide some additional technical assistance, particularly to the coordinators of the team, to be able to do this in a way that's really streamlined and leads to good concrete prevention recommendations. Other meetings, you may give updates on past cases. So at the state level, we generally don't carry cases over from one session to a next. It happens occasionally, but at the local level, particularly depending on when you're reviewing the case, if you start to review before that case is final, like for the example in the instance of a child abuse neglect case, we don't really want you reviewing that case until the investigation's over. But if your team talks about it, identifies it as a case, wants to put in the death certificate information in and have just a brief discussion without getting into all of the investigative reports, you can do that and then go back in later and update that case whenever the information becomes available. So you may have some updates for every case during the meetings. And then you'll be tracking prevention recommendations and actions. So, what we are doing at the state level is we've commissioned a full-fledged evaluation plan of our system as a whole, both the local and state level components. And one of the things that we really want to see is what happens as a result of these process. Are the process of reviews, are any recommendations implemented, what happens, so that we can demonstrate the need for continued resources for the system and the value of the system as a whole. So in order to track recommendations, you might bring data or information related to meeting recommendations that you've made in the past, or talk about progress that's happened since the last meeting. And then you may, if you really did want to move forward on something, need to have kind of a prevention meeting where you are identifying who's doing what, and making sure that the project that you're trying to implement moves forward. And then, education on prevention strategies and best practices. We are really hoping that, the recommendations that you implement are tied to best practices and what we know works in injury, violence, and suicide prevention. So part of what we'll be doing, particularly Leah Emmerich Anderson, who's our local technical assistance and prevention coordinator, she will be really looking at the literature and then getting that information to your local team, so that when you're having prevention discussions, you don't have to look things up or wonder what best practice is. You'll have it in front of you and can use that for your conversations and for identifying what you would like to do. So I've mentioned this several times throughout the presentation, but please visit www.cochildfatalityprevention.com. This is our collaboration website. This is kind of what the front page looks like there. We want you to use this website as a collaboration tool, because it's really our collective system, both the local and state components together. This isn't really a CDPHE thing, and although we have some information on the CDPHE websites, it's this process is all about what we are all doing together, and so we wanted to create a collaboration site so that you can interact with each other and share ideas. And as we move forward, we'll be giving access to post information here to all the local team coordinators, so that you can, share with each other what's going on and what you're doing if you choose to. This is also where we're going to be providing a lot of information as it comes out, new pieces to the operation manual or resources or answering questions. A copy of this webinar is on this website, so hopefully you have found it. But if you haven't done so already, please go to this section here, and if you put follow by email and type your email address in, it will send you a confirmation email to that address that you have to confirm that you really want to sign up for this. But this will be a way for you to get updates from us when we add new content to the website. So you will only get a message once a day if we've posted something that day. If we don't post anything new, you won't get an email. So this will just be if there's something new, and if we post multiple things in a day, which probably will happen for a little bit, it's okay. It'll only send you one email and kind of highlight what was new on there. So this is a great way to keep in contact with us and let us know or to be able to keep tabs on new resources. And we'll be adding stuff to all of these sections over time to kind of flesh them out. We're just now starting to get it up and running. So please check it out. Please let us know what's missing and what you'd like to see there, and we would like to make that happen. So what are the next steps? First, we need to have each of the local health agencies let us know what they're going to do in terms of a team structure. So if they're going to have a single county team or a regional team, multi-county team, we need to know that so that we can make sure to get the money to you in the most efficient way possible. We would also like to know a contact person at the coordinating agency, so that we have the right person to keep in contact, and as trainings or other resources come available, we'll make sure that that information gets to the designated person. And then most importantly, we need to know what you need help with. So we know that after the trainings, we heard a lot of feedback, we got a lot of questions, and as a complement to this webinar, there's also a frequently asked question document that is on the collaboration site. So please go in and locate that, and then be able to see sort of what questions and answers came up during the course of the 9 meetings. So we have some sense based on those questions what you need help with, but we want to hear from you. We need to know what you need from us in order to be effective, so please let us know how we can help. And finally, these are the key contact information for the local teams. Colleen Capsamalas, who is our new Child Fatality Prevention System Manager, her contact information is listed there. And then Leah Emmerich Anderson, who I mentioned is the Technical Assistance and Child Fatality Prevention Coordinator. We will add to this list our new data person as soon as that person is available, but these are your main points of contact, and please do not hesitate to contact either Leah or Colleen about information that you may need to help you design your team, or as we get going, I'm sure we'll all be talking and getting to know each other pretty well. And now it's time for a pep talk. So we want to end with a little video, a little pep talk. I know this was a long webinar, particularly if you listened to both parts of it. I appreciate your time and really do hope you enjoy this little pep talk. Please let us know what we can do to help you.
The world needs you to stop being boring. Yeah, you. Boring is easy. Everybody can be boring, but you're gooder than that. Life is not a game, people. Life isn't a cereal either. Well, it is a cereal. And if life is a game, aren't we on the same team? I mean, really, right? I'm on your team. Be on my team. This is life, people. You got air coming through your nose. You got heartbeat. That means it's time to do something. A poem. 2 roads diverged in the woods, and I took the road less traveled. It hurt, man! Really bad. Rocks, thorns, and glass. My parts broke. Wah! Not cool, Robert Frost. But what if there really were 2 paths? I want to be the one that leads to awesome. It's like that dude Journey said, don't stop believing unless you dream stupid. Then you should get a better dream. I think that's how it goes. Get a better dream and keep going. Keep going, and keep going. What if Michael Jordan had quit? Well, he didn't quit. No, he retired. Yeah, he retired. But before that, in high school, what if he quit when he didn't make the team? He would have never made Space Jam. And I love Space Jam. What will be your Space Jam? What will you create will make the world awesome? Nothing if you keep sitting there. That's why I'm talking to you today. This is your time. This is my time. It's our time. We can make every day better for each other. If we're all on the same team, let's start acting like it. We got work to do. We can cry about it, or we can dance about it. We were made to be awesome. Let's get out there. I don't know everything. I'm just a kid. But I do know this. So everybody's doing to give the world a reason to dance. So get to it. You've just been pep talked. Create something that will make the world awesome. Play ball.
Thank you very much for your time, and let us know how we can be of assistance.